You'll know when you have a wild woman. She'll practice her craft without boundaries. She is truly autonomous. Her loyalty is only to the family she serves. She will not allow herself to be held back by a system she didn't create.
This podcast is for the birth keepers who want to grow and change, who are open to learning through self-reflection and supportive community. We are creating a space to explore without judgment. We are remembering we were born wild.
Hello, everyone. Welcome back to the Born Wild podcast. I'm your host, Sophia Henderson. And today I have a three-peat interview with Lisa Rawson. And we've had her on the podcast 2 other times, and she's back by popular demand. Literally, we had somebody message and say, please, can you please talk to Lisa? I want to hear everything she has to say. And they were specifically asking about, can you guys please talk about licensing? And then somebody else wrote in and said that she would love to hear us speak about better birth options, like how to lobby for that, and insurance companies, coverage. But first, I'll hand it over to you, Lisa. Will you do an introduction of yourself as well as an update on what your life is like now? And we will also link your other 2 interviews in the show notes.
Thanks. Thank you for that introduction, Sophia. Yeah, so my name's Lisa Rawson, and I am a licensed midwife of California and a CPM, certified professional midwife. And then I do hold licenses in Oregon and Colorado, although they're not active. And then I graduated this June of 2025 from Bastyr University with a Master's of Arts in Maternal Child Health Systems.
Oh, amazing.
So,
congratulations.
Thank you. So now I have a master's.
Oh, great.
And I mainly did that because moving as I'm getting older, I want to move more towards away from being on call and looking at things like legislation and insurance and all of those other kinds of things, teaching. So I'm not exactly sure where I'm going to use that master's, but you need a master's to do any kind of higher kind of trickle down stuff. I've been volunteering with CALM, the California Association of Licensed Midwives, on the Saracoso, the Associates of Science in Licensed Midwifery at Saracoso Community College here in California, which is really pretty innovative. It's a hybrid program. But you will get an Associates of Science, so you can go on to get a bachelor's, get a master's. It's fully transferable and it's affordable. So, having more diversity in the midwifery community is number one goal, right? And more midwives in various capacities and different types of midwives. But this is a way for people to use a Pell Grant funding or in the state of California, community college is $46 a credit. Oftentimes it's waived. So this program would get you licensed and it's under $4,000. Wow. For just the program. There's book fees and things like that. So that's been kind of interesting. I'm volunteering at Bastyr University, looking at their Masters of Science in Midwifery. And then I am probably going to be teaching there, which is really interesting because the last conversation we had, right, was all about licensing and non-licensed midwives or practicing in a more hands-off way, more autonomous way while being licensed, right? And now I went and I got my master's degree and I'm going to be teaching at a university approach to midwifery in a state that's highly licensed and regulated. Although they do allow VBACs, twins, breaches, all of those things. And they do also pay midwives a pretty good wage for in their Medicaid program in Washington State for home births and birth centers. And they're actually upping that fee currently as we speak. So yeah, I mean, it's kind of all over the place, right? And then, I still have some repeat clients who I attending their births here and there. And those are really sweet, sweet births, very hands-off, very, very, very hands-off. A lot of those visits are talking about how the family structure is changing, or this pregnancy, or their birth desires, or when for me to come and what for me to do or really not to do. And then the postpartum visits are, I read stories to their children, and I make food for 5 hours and leave it in the freezer, do laundry, we chat, I'm basically doing grandma stuff from like, but then also, they get to ask me all these questions about their baby, because every baby's a new person. So every birth is different, and we process their birth, and it's just really, really sweet. And then of course I still work 3 days a week at the high volume clinic, the birth center that I work at. And that is that's also very regulated. It's a public healthcare facility. It's an accredited birth center. So it's kind of all over the place, the way that I practice and what I do and how I shift.
So funny how life can shift in just like a short amount of time since we last talked.
Yeah. Yeah. So, but yeah, I did my master's project on private pay insurance and incorporating community birth. So I will give you the link to that. It's a lot of words. A lot of words, but I did the literature review is actually 4 parts. And the first part is really about the history of midwifery in America. And that is really interesting. I think it's a great read. I'm really proud of that piece of work. And then it moves into challenges, scope of care, outcomes. So there's a lot of information in there about the good outcomes that we have in community birth settings with trained birth assistants. So internationally, there's midwives, but then in countries where there's no midwives, there's what we have is called trained birth assistants. And they're literally that. They are there to assist the mother in her birth, like in her village. I see them as like very, very traditional midwives, like a very traditional kind of pathway with a modern take. They do have meds that they can use, but they use them very sparingly because there's limited access. So, and I think we touched on this in our last discussion, where when you talk to midwives, like from areas where the postpartum hemorrhage rate is pretty high, out in the mountains, and their traditional birth attendants, they would love to have some miso on them for when they really need it. And it also saves them from going to the hospital, which is often like a huge trek, and then it introduces infection. And so really, that one of those sections is kind of talking about that, some good statistics in there. And then the last section is on insurance. And how we pay for community birth and how we pay for birth. And one of the cool facts is that with a 1% shift in the United States towards community birth, we could save $312 million a year with just a 1% shift.
And I bet we wouldn't have enough midwives,
No, we wouldn't.
Yeah.
Yes, we wouldn't. And so that's kind of like one of the issues. And so kind of one of my focuses that I'm moving towards kind of organically is teaching. So teaching, and then being part of, really, I'd like to teach and then get into some sort of director role for teaching programs. So one of the colleges, I have my eyes set on Bastyr. And part of that is because, Bastyr is giving university education, which is there is some very highly medicalized education in there, right? But they are trying to preserve that traditional way of midwifery. And it's a really gray area right now. And, clients in Washington State are finding that, and I'm having calls from them, because word has gotten out that I might be moving north. Anyways, through like various avenues and traveling of news, and that they're having a hard time finding midwives. They want midwives, but they really want these like hand-off midwives, and they're not able to really find that. Mm-hmm. And also the call shift. The culture in that state is a lot of them share call shift. So you don't really know which midwife you're going to get. It's maybe a 3 midwife practice, and then you're not exactly sure. And so I think that model, when you're wanting something really specific as a client, that's hard. That's a hard one.
Unless all those midwives are practice the same and are on board, it gets tricky. Yeah.
It gets really tricky. Yeah. So So
Mm.
yeah, that's kind of what I've been up to. And also, with any of those programs comes, retirement and health insurance. And, I'm going to be 50 next year. So I'm like,
Yeah, I think that's a big thing that midwives, as they start to maybe experience burnout or exhaustion, start to go, wait, I haven't been
yeah,
planning for this.
yes. Yeah, any new midwives out there, actually, really any time in your life, right? But new midwives, you're becoming a midwife, create a retirement plan for yourself. Like now, look into various ways that you can purchase your own 401ks and your own Roth IRAs and your own savings, or invest in real estate. That's always a good one. But just build that into your practice.
I always felt like there
Yeah.
needed to be a class. I don't know what the schools
Mhm.
are teaching now, but when I was a student, there were a lot of things that I left that I had no idea and I had to just figure out on my own. And they're all the business side of things and the back end side of things,
Yeah.
like setting up a lab account and like how to partner with insurance companies,
Yeah.
all this stuff you just realize you don't have it set up. And, like I
Yeah.
remember a client who was like, "Oh, you can draw my labs and just like run it through,
Mhm.
they'll just bill my insurance." And I was like, "Yes." And then I left the appointment going, "I don't have a lab account." Like
Mhm.
I need they didn't give me like a checklist of things to do
Mhm.
now that you're on your own. So I think that would be like such a great program too, where when students graduate, unless this is included now, we're like
Mhm.
somebody to walk them through all these things.
Yeah. 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 There schools are starting to incorporate more of that, but still it's not a lot, And also one of the things is like, because we don't have like this national standard, which, the NACPM is like working towards, because of that, like you have these hybrid programs, right? So NMI has got students from all over the country, but all of them do, really. They all have students from all over the country. And so every state is different. Yeah. So then there's that, like when you're teaching, like how, you could teach some basics, but every state will have its nuances.
Yeah.
So
Yeah.
yeah, it's really like the preceptors also need to be helpful with that, I think.
Yeah.
Yeah.
You were mentioning about like the history of midwifery in America, and obviously we will all read the link you sent. I'll put it in the show notes. But was there something from it that you thought was new to you or fascinating that you could share?
New to me, I don't know.
Or just maybe that you think most people don't know?
Yeah, I think, well, one thing that's pretty fascinating and is something that it's like a little party thing that I pull out, sometimes I'm like, did you know? So midwives, so traditionally there was indigenous midwives here. They were already here before white colonizers came. And when they came, they brought their slaves with them, and they had their granny midwives. And then when immigrants came, large, Irish population, Italian population, they had midwives that were coming over as well. So there's really three sectors. There's the indigenous population, the immigrant population, and then the granny midwives who were brought over as slaves. They were the original midwives. And then it was in the early 1900s that Dick Reed, he published an article basically starting to slander, I think it was like 1918. He started to slander midwives. And this was right around the time of the American Medical Association starting. And it was also right around the time, a little bit after that, that ACOG was formed. And he basically was saying, that they're disheveled, uneducated. It was like a very smear campaign. It wasn't really saying you shouldn't have midwife, right? So that was not the purpose of it. The purpose of it was like, women were not being included in the AMA, American Medical Association, and they weren't being included in colleges either, and we didn't have rights, right? So the way to do that, to get them out of that and to get people towards something else, was to do a smear campaign. Then on the tail end of that, in like the 20s and the 30s, came on the medicine to like basically save the uteruses from all the pain. And there was also this like movement, right? So there was the 20s were like the booming 20s, right? And in the 30s, it was very much like, oh, the sophistication of it all. And the Industrial Revolution, like the sophistication of all of that was coming around, right? So you had automobiles, lights in homes, right? All of this kind of like glamour. And so high society women started to think like, well, I don't want to be in pain. Like, oh, this terrible childbirth, this terrible, and I mean, mind you, like they're wearing corsets and things like that. So, their bodies were also not the same as, farming women or like regular folk, right? And so they started using ether, which is what they were using for dentistry. And so a dentist's wife basically was like, why can't you just bring some ether home? And then he did. And then she used it. And then she told all her friends about it. And then there was like this dawn of age of like pain-free childbirth was like the selling point. Mm-hmm. So it was like a smear campaign against the midwives. And then it was pain-free childbirth. And of course, they had no idea what they were doing to these babies either, like that was not even a thought. And then what happened was literally within less than a decade, you had it going from most people having their babies at home with midwives. And I'm talking like 100%. It was very, very uncommon. Like less than 1% were having a family physician or a doctor attend their birth in the United States at that point, to being 2% were out of the hospital attended by midwives. Like even if they were home births, they were being attended by obstetricians and doctors using pain medication.
What did you say that time frame was?
It was from it was less than a decade. I want to say by 19, I'm remembering this correctly. I should just pull it up, but it was like 19.
We won't hold you to it.
62, I think it was, or something like that. 19. And then the rest, and then it was under 1% by the 60s. So it took, of those people left having midwives and having babies, all of them were attended by granny midwives or indigenous midwives. Oh. Yeah. So it was a very quick, super quick, happened very, very quick. Mm-hmm. And then it was also the advent of hospitals. And so then they started moving women into the hospitals. And then you got the Twilight era and all of that terribleness.
It's amazing. When you said 1920s, the first thought in my head was that wasn't that long ago. And then the second thought is, wait, we are in the 20s right now. That was 100 years ago. Like, right. I thought of it that way. You're like, wait, we're in the 20s again.
Yeah, we are. Yeah. And then, the timeline that I wrote about goes through, the advent of the CPM, the movement of the CPM, which was created by a group of white women who basically wanted their rights. It came out of that whole movement of the 60s of like body autonomy, down with Nixon, like all of that, right? And no war, back to the land, people taking back their autonomy in several different ways. And so, that came around. And the first freestanding birth centers were open. One was in Santa Cruz and one was up in Seattle. And I believe it was 1976, which is like the year I was born. Yeah. And so that happened pretty quickly. So in the 60s, but one of the things that is notable as well is that, the white women who joined together to have their babies and start this movement, they didn't turn to the granny midwives and the indigenous midwives and the immigrant midwives that had been doing this work, like, and continuing in their communities and like keeping this like small little flame alive. They turned towards male family physicians and male OBGYNs that were practicing out of the hospital. So there was, in that time period, there was like in the 50s and 60s, there were family doctors. They were men and they were white men predominantly. I mean, like 99.99% of them. And they were attending people in their home for all kinds of things, for diphtheria, pregnancy, suturing them when they got a dog bite. Like, all of those things. They were family doctors, right? Community family doctors. So these group of women, instead of turning to midwives, they turned towards family doctors. And that to me, I think is a really, really, really important factor, because out of these books and all of this, the Meek, NARM, all of this, right, came from that. All of these organizations that are licensing, regulating, blah, 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 they came from these group of women who, instead of learning from midwives, they chose to go and learn from white men, family doctors. And to me, that is really telling of what we're teaching and what we're learning, and why we are like, where's traditional midwifery? We have all these midwives. Where are they? Where's the traditional midwifery? It's because our new movement of the CPM is not based on traditional midwives from the minority communities, the LGBTQ communities, the indigenous communities, the granny midwives. And now what we're seeing like a shit moment. And a lot of these midwives are elders, and we are trying to like bring some of that back. And we're trying to learn, but a lot of these traditional midwives that we're trying to learn from are not from our country, right? So they're from Guatemala, they're from indigenous communities in Alaska and Canada, they're from other countries. And so there's some disconnect there, right? And I think that one of the aha moments for me when I was doing the timeline was like, oh yeah, these women chose to go and learn from white doctors, men.
Do you think it's because they bought into the smear campaign, or they were like wanting to be seen as professionals, or?
Yeah, well, I think by then the smear campaign had done its job, and it was just kind of like, it was like kind of gone all the old days of old kind of a thing, right? But what I think what it was that this group of women were educated, had bachelor's degrees, master's degrees. Their husbands wanted to be in the room with them. They were that like heteronormative white couple that had some funding or some ways of means outside the system, privilege, and I think what they thought, I don't know if it was a conscious thought. And in fact, I don't think it was a conscious thought. But they also did not consciously think to seek out the granny midwives and the indigenous midwives and learn from them in their own backyards. So it's kind of interesting. And I wonder to myself, like, if they had, would our movement today be different, right? Would those boards of leadership be different? They probably would. They probably really would. We'd be seeing color, right? So now what's happening is we're shifting more towards, as women of color and indigenous women get more education, they're now starting to take up space that has rightfully been theirs all along. I mean, we are a country that's based on, colonization, and that colonization has brought a lot of different immigration and slaves, and the indigenous people were here already. So there's a lot of different peoples on this land, right? And so now we're starting to see more people, like the president of NACPM is a woman of color, and we're starting to see that. And it'll be interesting to see if it shifts more towards trying to bring back some of that traditional knowledge. What's left, like what is left. Mm-hmm. And I'm like, the 70s wasn't that long ago. It's like 50 years ago. And so much has been lost. Like, how much could have been saved, I wonder.
The midwife Bliss, through Birthing Instinct, she has a project.
I think it is the Bridges Project.
She's trying to locate all the elders while they're still here to interview about their experience and their wisdom before it is lost. Yeah.
And some, I will say, like, a lot of midwives who were in communities were learning from the granny midwives, like in their communities, and indigenous and immigrant midwives in their communities. But the model that moved towards like national licensure, that group and that model was based on, and I mean, it's talked about in their books about, they give thanks and credence to the family doctors, the male family doctors that, taught them.
Yeah. Yeah.
Yeah. And then a lot of their readings that they had as well were based on what men wrote.
I feel like we already talked about where we're at now, and we want to talk about how to get where we want to be. And so it's important to know where we came from. You know?
Yeah.
Yeah. So
Yeah.
we talked about where we came from briefly. We could do a whole podcast on it. We talked about
Sure.
where we're at and how like a lot of midwives are trying to find this balance, and families are starting to be like, yeah, maybe I want less, but if I want more, like I want you there. And so what is like, how do we get to have better outcomes? The person who wrote into us was like, how do we lobby for better outcomes? How do we get insurance to cover home birth? You know, Leah, my partner at Born Wild, she worked at a birth center in Germany a while back, and you just like swipe their insurance card, like, but it
So
was
nice.
also negative 30 degrees, so she couldn't hang. But like, how do we get there without compromising, you know, like
Right.
the autonomy piece? Yeah.
Yeah.
Like, what are your thoughts around all that? And for people listening who are like, I want to do something.
Yeah. Well, in my master's project, I did a capstone project and I created a toolkit. And one of those toolkits is how to choose insurance for yourself that will cover community birth. And then one is how to get into legislation. One is how to find a biller or become a biller. And so I'll link that too. There's like a little file, and then you can just use the toolkit. I extrapolated that from the 90 pages, or you can read the whole thesis if you want. Yeah, so local legislation, definitely you want to get involved. We need volunteers, we need boots on the ground, learning where there's so many, it's multifaceted. So you kind of got to like pick like, okay, am I going to concentrate on laws, or am I going to concentrate on education? Am I going to concentrate on insurance reimbursement? One of the reasons I did my capstone project on private pay insurance is because 51% of births across the United States are paid for by private pay insurance. Medicaid has got a lot of focus, and that's great. And that serves the underserved communities, right? So that gives us, but there is a lot of concentration on Medicaid and Medicaid reimbursement. And states are picking that up, and the NACPM is like working with that. But private pay insurance, the way that we get them to pay is through the Social Security Act. So there's two ways we can do that. One, we can lobby per state, and like, for instance, Louisiana passed a bill where private pay insurance is legally required to pay for any service that's legal for pregnancy in the state of Louisiana, which CPMs are licensed and regulated there. Now, what happens, that the law is there, what happens is then the midwives and then the clients have to actually hold them to task, right? So you have to hold them to task. So one of my toolkits is what to do if your claim is denied. So because they will deny your claim. It's the private pay insurance is like a well-oiled mafioso, so they will deny your claim for some reason. They'll find it. And then your insurance commissioner, how to like file a claim with your insurance commissioner if you ultimately have to do that. But people have to do this, right? So we can create laws, and I use the Louisiana example because we can create these laws, and governors and legislation and the House of Louisiana can pass these bills. But until somebody holds the insurance company accountable, they'll just keep denying it and be like, well, we didn't know anything about that.
And it's so hard because when you're going through all this, you're postpartum with a new baby.
Yes. You're postpartum with a new baby. Yes. Yeah. 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 So there's that. And I think that, it's a vulnerable population. So, postpartum families are a vulnerable population, and they've already paid for their care, and it's really about getting reimbursed, right? So midwives either need to join forces and hold these insurance companies to task by actual lawsuits, or, insurance commissioners. Midwives could maybe start to actually fill out the insurance commissioner on behalf of their clients. So they could, I know it's more work for us, and that's like gosh,
Would
more
you
work for
say
us.
this in
But
addition to a biller, or would that be its own?
that would be its own. So the
Okay.
biller would go through the process of billing, and then it would get denied and denied and denied. And some billers will actually file a claim with the insurance commissioner on behalf of, because they're passionate about it, right?
That would be a good question to ask them if you were a
Mhm.
family.
Yeah, a family. Yeah. Or even a midwife. Because
Okay.
what happens is it tends to be that midwives will join forces with a biller,
Mhm.
and then that biller will try to get you in network or negotiate rates, or just not negotiate rates, but try to get you in network with Aetna, Blue Shield, all the things. And then they do the billing. So then it's the actual midwife who's being denied, not the client, right? Some billers are on a per client basis. They actually bill for the client. So like the client fills out the stuff, and the midwife signs off and sends them something that they did, fills out their forms. So then the client would be the one to actually ask that. And one of my toolkits, I think there's 5 parts to my toolkit, and one of those is it goes through the billing process. It also goes through the process of when you call your insurance, what questions to ask, and to see if community birth is covered. And then depending upon the state that you're in, depends upon the language that you can use to, strong arm them to be like, well, did you know that, Louisiana passed HB blah, 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 right? So yeah, legislation can bring around those bills that are passed, or governor proxies. So the governor can make a statement, like I think in Illinois, they did that and made a statement saying that, private pay insurance has to pay whatever Medicaid pays for. Well, Medicaid pays for community birth. So you can use that as leverage, right? But it's the follow through. And usually people have more time when they're pregnant. Also, pregnancy is seen as a life event that you can change your insurance, your private pay insurance. So there's some information in the toolkit about what you want. Like, what do you want to change your insurance for? What type of insurance? And really, like, if we just had a single payer system, like all of this would just be like the Germany, like swipe a card, right?
Yeah.
Yeah.
Yeah. It
So.
gets so complicated on purpose for
Mhm.
me. It's almost like speaking another language. Leah could wrap her mind around it a lot better than I can. It all makes sense to me in the moment. And then if somebody was to ask me a question about it later, I'm like, I will give you Leah's direct number. Because I also don't want to be wrong, and
Right.
misspeak.
Yeah. 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 So there's some questions in there of what to ask when you call to like find out what it'll pay for. I will say that health shares are also catching on. Christian healthcare ministries and like some of them are non-religious, but health shares, they are catching on as well. And what was happening was that midwives were balloon paymenting, right? So they were like charging hospital rates essentially. And the health share ministries were just paying it. But they've now come to understand, like, wait, we're supposed to be saving money with community birth. And so now they're starting to put caps on what they will reimburse. Health savings plans are really great. So when you sign up with your employer, they'll ask you during your signing up for your health insurance and stuff if you want a health savings account. Yes. Yes. That is very easy to get paid for. Yeah. Because basically it's anything, you just need a receipt.
Yeah.
So you give your client a receipt for whatever your fee is. They have, X, Y, and Z amount in their health savings account, and then they get that money back.
Awesome.
Yeah.
Yeah.
But it is, insurance is a beast, legislation. What you want to do to get involved in legislation is call your local states, like for us, for California state, it would be CALM. But every state that has some sort of licensing or regulation, even Utah that doesn't have regulation, has an association of midwives. So you would get in contact with them, become familiar with your state, become familiar with those web pages and those terminologies and what they're working on. NACPM, the National Association of Certified Professional Midwives, is always looking for volunteers, and they can plug you in with like their state sponsor. So NACPM has a state sponsor in every state. If your state doesn't have one, you could become that person and create create a collective of volunteers. Yeah. So there's definitely a lot of ways to get involved. There is a movement to get TRICARE to pay. TRICARE is the military insurance. And if TRICARE starts paying for community birth settings, then we have a really good chance of lobbying to get us included in the Social Security Act. And once we're named in the SSA as primary healthcare providers, then we're seeing, all those discounts that you get during COVID for like, are you a community healthcare worker? And CPMs were like, I am. And they were like, we don't recognize you. It's because of the SSA. Yeah.
Interesting. Oh my gosh, my train of thought just...
It's okay.
There was something specifically about that I wanted to ask you. I know it's gone. I don't remember.
It'll come back to you.
Yeah, I always tell pregnant moms, I'm like, it's looping around. Just give it a minute to come back.
Yes.
And then I always
Totally
say
looping,
it's osmosis. It's because I'm around so many pregnant women that
Mhm.
I'm not pregnant.
Yeah.
I have the same side effects.
Yeah. And you're a mom.
Yes.
And you're a midwife and you got a lot going on, and it's just like how it is, right?
Yes, totally.
Mhm.
It almost just came back to me and then I lost it again. I think it's because this anemia thing, I'm dealing with anemia.
Oh.
Like iron infusions, and then it like drops again. So now I'm looking at like gut health. It's so hard to stay healthy.
Yeah.
So complicated.
Yeah, it is. Have you heard of the Iron Protocol group on Facebook?
No, send that to me.
Yeah. So you should go to the Iron Protocol group on Facebook. And Augustine Colebrook, she wrote her master's thesis on iron, essentially. Yeah. And I think she's has it linked there. But yeah, you'll learn a lot.
I want to learn more and more about ferritin too, because so many women have low ferritin that like part of us jokes, like we had somebody recently that came back with regular ferritin levels and we were like, what if we found out that it was actually normal to have low? And like just because it's so common, we're like, what is going on here with people?
Yeah. Yeah. You're going to learn a lot about iron, ferritin, binding iron, all that stuff if you go to that group.
Okay. Good to know. One thing I wanted to chat about, I don't think we have time, so maybe I'm going to have you come back for part 4. I wanted to talk about like chart reviews, because I know it's something that you still do, or have you kind of like distanced yourself from that? I know that it's like there's a term for it. What is it?
You mean just the chart review, or you mean like the independent contract? I'm not sure exactly what you mean. Blast me.
I think there was a time where we had chatted, and I might be mistaken, where you did maybe chart review when there was like a peer review that was needed or a discrepancy grievance. And you like maybe even did a course on like how to review charts specifically. Am I misspeaking?
No, I didn't do a course. So I've done reviews, plaint reviews for NARM and also the California licensing board. And then I've done individual peer reviews that are actually more like chart reviews. So for people who have poor outcomes or like really long, terrible births, and they're like, I just don't know what I missed. Newer midwives who are needing some guidance of like, okay, so I've had, all past 5 of my primates have all got stuck at 6 centimeters and ended up like, what am I missing? And so like that kind of like macro big picture. And then we like focus in on, okay, this is a point where you chose this. This is another option to choose, another approach, another way to look at it. And then that kind of like opens another door, right? A lot of people are practicing by themselves, or they're practicing with a partner, and then it's just the 2 of them. And you're kind of in a bubble, right? And so sometimes it's nice to have somebody come in who was not there, who does not have any attachment to the client or the outcome or anything like that, and just look through things and be like, and taking notes and being like, okay, so what were you thinking when this happened, when you wrote this? What made you choose this? And it's not a punitive thing. It's not a judgmental thing, because God knows, hindsight is 2020, right? That's why we say that, right? And so it's more of like an opportunity to learn and to like have some reflection.
Yeah, because hopefully you're always wanting to do better, and we're human, and
Yeah.
um,
Yeah.
learning from experience.
Exactly. Yeah. Just learning from experience. So I do still do that.
Okay. Well,
Now that
maybe because of the time constraint, maybe add something that was just a little teaser, and I'll bring you back because I think that would be an important topic for student midwives,
oh,
families, just
yeah.
like how to chart,
Mm-hmm.
and
Yeah.
like what to
Mm-hmm.
do when there is a grievance or, somebody's not happy,
Mm-hmm.
outcomes
Yeah.
or like you were saying, the midwife is just like, what, like everyone's fine, but like, what did I miss,
Mm-hmm. Yeah.
Yeah.
Yeah, I think there are courses out there on charting. Sometimes the courses are like you take the course, but there's these nuances, right? And also, even for the free birth community or I just call it the unassisted birth community, the unassisted birth community, like reviewing their birth with them
Mm-hmm.
from a perspective of somebody who's gone to hundreds and hundreds and hundreds of births. Sometimes they call and they just want to like review their birth, and some of them have it on video. So watch the video together, pause the video, and then like, okay, so what were you feeling in this moment? What is your question? Yeah, maybe pulling a leg up, because sometimes people, even though they have their baby at home unassisted, it still can be traumatic, right? A home birth can be traumatic, an unassisted birth can be traumatic. These are huge, major life events, right? Even just reviewing that with people who are unassisted and is something that I do too. I don't think that you have to be a midwife to, know about birth.
Well,
So
will you plug yourself real quick and just let people know how they could reach you? And we'll include it all in
sure.
the show notes.
So my website is no longer there, but I will include a URL which has my contact phone number and email
Great.
for my capstone project. And then it's Lisa_Rawson LM. I believe that's it on Instagram. That's my IG. And then also Mountain Valley Midwifery on Facebook. And I don't mind sharing my phone number as well on the show notes.
Thank you again for coming on.
It's so good to see you.
You too. And we'll see you for round 4.
That sounds good. Bye.
Thank you for listening to our podcast. If you enjoyed what you heard, please rate, review, and subscribe. If you'd like to follow along, you can find us on Instagram at Born Wild Podcast and Facebook. You can go to our website at www.bornwildmidwifery.com. See you later.